So Zubin and I have collaborated for several years now on finding ways to use data to help people who are at risk of having a behavioral, what we will call loosely a behavioral crisis that might engage first responders or result in a 911 call. We want to find better ways to serve individuals who might be in crisis, but also their family members and the first responders, because everyone involved in that is a fragile human that is navigating some really challenging situations. And if you think about the predicament, everyone ranging from the subject of that call to the 911 call taker who may be talking to a frightened mom for 30 seconds whose son just punched her in the face, trying to figure out, what do I do to help these folks, and what kinds of information do I give to the first responders, and all the challenges that come with that. And I would say another thing that Zubin and I are very focused on with our colleagues is not just how to manage that immediate encounter, but sort of then what? And we put so much burden on the 911 system to deal with complex problems, whether it's serious mental illness or substance use disorders or intellectual and developmental disabilities. And if the first response doesn't go well, there's a cell phone video. There's never any cell phone video for the 8 times the person called to try to get housing assistance and they never got a call back. For all the different systems that failed that are not 911, that were often kind of the prequel for whatever the crisis was that resulted in that 911 call. And so we're trying to think of this use data to take a preventive approach, take a follow-up approach to see if we can provide a better systemic response in these challenging situations.
The one thing I think I might add to what Harold just said is, in terms of thinking about how you might address some of the issues that we might talk about around 911, one of those potential solutions is preventing people from having the need to call 911 to begin with. And so part of our work is, can we use data that's collected by city agencies from the 911 system itself to then help prevent future bad outcomes that might happen as a result of contacting 911. We've actually used data in sort of 2 different approaches. One is using data directly from 911 on calls that are received by dispatchers to try and identify whether that particular call might have a behavioral health incident, might lead to a behavioral health incident with the potential of with the hope of potentially improving decision making right at that very important sort of first initial contact. We've additionally used data from, for example, the Chicago Fire Department, Chicago Police Department, ambulance runs to try and identify additional information about individuals who might contact 911 for the purpose of the other type of prediction that I previously mentioned, which was sort of trying to identify risk a priori before people contact 911 to explore 2 different potential data-driven approaches for addressing some of the issues we'll be talking about with respect to 911.
So I think, by the way, it's a privilege to work with data scientists like Zubin in this effort, because one of the advantages that we have with this city data is we really have massive amounts of data. And so we can use statistical techniques like machine learning to see patterns that would be very difficult to see if we didn't have a big city like Chicago, where we have hundreds and hundreds of thousands of calls over several years, and that we can sift through. Now it's a big challenge to use this data. It's a challenge from a human subject's perspective because we have very, very sensitive data. It's a challenge, and of course, it's an analytic challenge to try to make sense of this data. It's also a challenge to try to understand what some of the data mean. So one of the things that we do that complements the machine learning is we talk to people who are EMTs, who run homeless shelters, and we say, when do you call 911? When do you not call 911? If you said this person was aggressive, what do you mean by that? because there's a whole process through which this data are generated. And, you have an EMT who's rolling up on the scene. There's a person who has some challenges, and the EMT is trying to document in the case notes and the narratives, sort of this is what I think is going on. And they don't have time to do a full sort of OJ trial documentation of that. And then, so we need to understand from them, tell us about what these data mean. And I would say, as our work unfolds, the ability to not only to combine the machine learning with, in a mixed methods way, with interviews, with policymakers, with frontline clinicians, with families, and with individuals who are consumers of mental health services, has been, it's really important. I should say we're in the middle of that. We have a lot of work to do to achieve that, but putting that data in context is really valuable. And to understand also some of the data that we have, there's some really interesting and difficult ethical issues that we've also worked with. One of the things that Zubin and his colleagues have been able to do, which I think is really interesting, is to say, okay, we do our predictive analytic models, we throw everything at it. Well, race comes out as one of the variables that might be predictive of certain things, or someone's criminal record might be predictive. There's lots of reasons why you wouldn't want to use those variables for very sensitive decisions about people. If we remove those variables, what does that do to our ability to predict things where they seem to have some predictive value? We do what are called leave-out experiments, where we intentionally go into the algorithms and say, here's a bunch of variables you can't use. What does that do to our ability to inform policymakers and clinicians and first responders, with the predictive analytic tools that we have? So I think one of the most exciting things that we have, and one of the most difficult responsibilities we have, is to understand, how does the predictive analytics connect with other ways we can learn about the population and the people that need help, and also the kinds of ethical, legal, administrative constraints that you have in how you want to use very sensitive data that people share at very vulnerable moments of their lives. So that's certainly one thing that I would add. Zubin, shall we talk a little bit about the comparison of the high users and the machine learning stuff?
So, typically when we, so my background is in predictive analytics, particularly predictive analytics in the service of helping public agencies, people who work with public agencies, not-for-profit organizations, potentially make better decisions with the data that they have. Now, there are serious challenges to understanding whether this algorithm that you've built is either doing better than status quo, or is going to improve outcomes like it might suggest in your historical data. And so, the first thing that we did in this project was sort of looked around to see, okay, what is the status quo right now with respect to using data to identify these potentially problematic situations. And the sort of very common model that's used in a lot of jurisdictions is this thing called the high user model. You might elsewhere it's been referred to as sort of the frequent flyer model. It's basically individuals have a lot of contact with city agencies. And the idea is, for a particular thing that you might be interested about here, it's behavioral health involved incidents with police is the project I'm referring to. The version of that high user model is how many times this individual sort of come into contact with first emergency response previously to this, and then you sort of say, okay, this person did it 5 times, this person had 4 contacts, so the person with 5 contacts is riskier by sort of that method. So we sort of horse raced the machine learning with this high user approach, with the idea of seeing, how much better could you do? What is the sort of, and speaking to what Harold just mentioned, what is the difference in profile that's identified by a machine learning approach versus this high user approach? Because if it's the case that they're identifying different individuals, if the machine learning method is identifying individuals who might have more previous sort of indications of police contact. A high user is not, or higher indications of homelessness, and the high user model is not. That's very much going to affect the actual sort of downstream intervention that you might apply. And so, when we're doing these comparisons, we both want to compare with respect to accuracy, but also with respect to sort of the profile of the individuals that are being highlighted. And what we found is, the machine learning methods, by bringing in these additional information that we have access to beyond just the prior number of counts, helps us identify a different subset of individuals. In particular, what's potentially very exciting about this machine learning approach is, if you use something like a high user approach, by definition, people have had previous contacts with, emergency responders, potentially serious previous contacts. What we found is about 30% of the individuals identified by the machine learning model didn't have these previous encounters. And so this really starts to speak to the opportunity of preventing future these future encounters. And here it is right in the data. There's people who haven't had these contacts that the algorithm is saying at high risk. If we can prevent them, do it at scale, that could potentially have, speaking purely from a public policy cost-benefit lens, that could potentially have very promising outcomes.
I'll just add one thing to that. If you're looking for the 300 people in Chicago who are at the highest risk of getting into a fist fight with first responders in the next year, the high user model is going to work pretty well. There's a group of people with very profound challenges who have frequent contacts. If you're trying to do prevention, or you're trying to just field an intervention that can serve more, that's not a super intense intervention, but that could serve not 100 people, but 5,000 people who are at risk. The machine learning models can be very, very helpful there. And also the machine learning models tell you more about in some ways about why the person may be having an issue, or at least an aspect of the person's profile that may help you clinically. So, one thing about the high user model is people have all kinds of reasons why they have frequent encounters with first responders. And those don't always line up with the available interventions that we have. If we say, hey, we could do assertive community treatment for people with serious mental illness who might require additional help. A lot of the high users, that's not their issue. They don't have a serious mental illness diagnosis. That's not what's leading to whatever's going on. When you're doing the machine learning, you can say, well, we've identified a somewhat different group, but we've identified some clinical characteristics that are associated with a high risk. And then we can talk to our clinician colleagues and say, okay, what can we do to try to help people who seem to be lighting the bell in our predictive analytics because of these clinical features that come out. And that can be quite valuable, because I do think that there's so many reasons why people become a high utilizer, and they don't really point to one set of interventions that are going to help that entire group of people. And I must say, one nice thing about the data, by the way, is we've spent a lot of time, particularly in some of our piloting intervention work, we just read a lot of individual people's stories. And you see, for example, most common crime that leads people into contact with police, who are sort of in this group that we care about, basically shoplifting alcohol from the supermarket, things like that, stealing a pair of socks from Walgreens, survival crimes. And it's so much more valuable when you can get some sort of granular and tactile understanding of what's going on, compared to just saying, this guy had 17 encounters with law enforcement over the past year. There's just so many reasons why that could be happening.
Just picking up on what Harold said, in a sense, actually, what we do see at the end of the day is the thing that's most predictive of sort of future behavioral health involved encounters with police, prior behavioral health involved encounters with police. This is sort of a regularity with a lot of these prediction exercises. But what's sort of particularly challenging, and what we've been addressing, is the actual measurement of a behavioral health involved encounter. That's actually, if you think, I encourage you to sort of step back and think about how you would sort of come up with that definition. and then go look for it in data. It's actually pretty challenging because, police departments don't really keep track of this. You might get it in healthcare records, but there's access issues. And so what we've done as part of our work is because first responders, particularly on the EMS ambulance side, from our perspective, an amazing job of documenting what's happening. Sure, there's differences across individuals, which I'm happy to talk about that could lead to bias, but they spend a lot of time writing what's happening in a particular situation. And so the technical challenge for us was to actually go and look at this text, this information that's being recorded, these impressions that are being recorded, and then extract information that gave us indications of behavioral health involved encounters. And so by being able to sort of do something, which at the end of the day is a simple thing, measure this thing that we care about and then predict for it, that's where we think that there's a potential, a lot of value in this approach. And the other thing is that it's probably going to be different in each different jurisdiction. And so another part of my work that I think is also relevant here is the need to, any jurisdiction that wants to do this should attempt to do this with their own data rather than sort of importing. And so, we work in Chicago. Probably if you wanted to do the same thing in LA, you could sort of take our general approach, but you really need to look and see how people on the ground contextually are documenting that situation in a different jurisdiction. And so I think the solution to a lot of these problems, at least at the low-hanging fruit level, is just sort of counting the right thing. And so I think that's, while it sounds simple, you actually need to make sure you're doing it right, because there's both potential to make sure that you're measuring the thing you want to measure and that it's being measured without bias. I think one thing that we are feeling promising about is that you can use data that's being collected by public agencies to predict risk of these types of incidents. It looks like there's a path forward there. What's missing right now is, how do you link up different types of people who are high risk with interventions that would work for them? And so I think the things that I would like to see, collectively being worked on, with me working on parts of it, are trying out different interventions and then using the results of those interventions to then feed back into these prediction models, so that we can both predict who's high risk and which one of the interventions that have been shown to work might be more appropriate for them.
I guess the only thing I would want to reinforce would be, every single person in the chain of a 911 call is a fragile human in really difficult situations, trying to do the best they can. That's true from the subject of the call, to the call taker, to the first responder, to the family member who made the call, or maybe it's some guy in the bus station who saw someone having a challenge. And we have to think of this in a systemic way and create systems that support every one of those human beings, and particularly to have the right balance of accountability, improvement, but also compassion, and a systemic rather than an individually condemnatory approach. When something goes wrong, when you see if you're watching 20 seconds of a movie, of a 2-hour movie, when you say, look at a cell phone video of a 911 encounter, or you read a story about what happened when the fire department came to the home of someone in a difficult situation, and maybe that person didn't act towards those firefighters the way that he or she would have wanted to in that moment. Maybe those firefighters didn't act towards that person in the way they wanted to, or maybe there was something else happened at that encounter. And I think we have to bring some humanity to that, and to just remember, how challenging this is for everyone involved. And it's like medical errors. You look at a single medical error and say, oh my God, how could the doctor have missed that diagnosis. And, he's a fragile human being, and there's, he got that right 99 out of 100 times. And if there had been a system that had backed him up and had another person or some other way to, to have his back in case he did make a mistake, he might not have made a mistake in that 100th case. But if you just watch, if you just read the one paragraph, oh, this was the mistake, it's very easy for the outsider to really be very harsh towards that person and to lose a little bit of our humanity in our assessment of what happened, and to think that we have to have perfect people in our systems as the response. And that's not the way human life works. So that's the one thing I would add.